Hello, everyone, and welcome to another session of the Virtual Global Spine Conference. My name is Ali Baj. We're happy that you are joining us today, either live or if you are watching this later on. I'm absolutely thrilled today to welcome our guest speaker, Dr. Theresa Williamson. Dr. Williamson is a neurosurgeon at Massachusetts General Hospital in Boston. And she completed her medical degree at Yale University, followed by neurosurgical residency and fellowship at Duke University. Dr. Williamson is really one of the renowned figures in spinal neurosurgery nationally, but also has a unique expertise and passion for bioethics in medicine in general. And certainly today she'll share with us how that ties into what we all love and do, which is neurosurgery, spine surgery, and we're very excited to have her join us today. So, Dr. Williamson, thank you for joining us today. We are excited to engage you in this very important topic, which I want to personally thank you in advance for picking a topic like this, which is certainly a little bit different than what we're used to in terms of cases and spine cases, but this is going to be so important for a lot of people that are watching this, both whether they're expert surgeons or whether they're in training or medical students. So thank you so much for covering this really important topic and for joining us.
Awesome. Thank you so much for having me. I really appreciate it and love these lectures. So I'm very excited to contribute some of my own cases or case examples, I should say more accurately. And as I get started, I'll say I will talk about some cases. There are some cases that are sensitive issues, but all patients' stories have been changed so that nothing reflects sort of the accuracy of the situation, and no patient their identity will not be exposed as we present these cases. So I titled the talk Ethical Dilemmas in Spine Surgery, Always Do the Right Thing, ? Because I think doing the right thing in spine surgery is a really complicated question. And as you pointed out, part of the reason why I'm interested in trying to figure these things out. So what I want to do today is talk about Ethics 101. So just give us a language to talk about ethics, because I think often when I tell people that I do ethics and I'm a spine surgeon, I get one of two responses. Is that even a thing? And then the second response is pretty much like, I already got that. Like, I know what ethics are. I know how to do the right thing. And why did you have to go do a fellowship in surgical ethics to figure it out? And I would say that there is some language to the oftentimes common sense rules, but also things that are nuanced that are helpful to think about challenging problems where tensions really do exist. And it really is hard to figure out what the exact right thing to do is. And talk about sort of what challenges in that regard are unique to the surgeon-patient relationship versus just a medical doctor's clinician relationship with the patient. And then go through some cases and try to highlight some of the key ethical principles as we do so. So starting off with the Ethics 101. All right, so clinical ethics really became a field in the 1960s. I did my surgical ethics training at the University of Chicago, and Mark Siegler's there, and he's in some ways considered to sort of be the father of clinical ethics, though philosophers have been thinking about ethics issues for thousands of years before we ever, put a name to it. But a lot of what this came from was because of sort of a shift between paternalism and really physician-driven decision-making and this idea of patient autonomy. Maybe the patient should have some type of role. Things that I thought were kind of crazy that I learned were in the 1960s, we didn't always tell patients they had cancer. We thought you don't need to know how is it serving you to know that you have cancer? It's not helpful. So we'll just give you this drug and, hopefully you'll get better. And if not, so be it. And so, and things like mechanical ventilation didn't exist, right? So people used to die at home. It's like a kind of novel thought that, human beings used to die at home. Now it feels like pretty much everybody goes to a hospital, has a huge end of life decision, has, all these options for treatment upon treatment. In the US, we do a ton of surgery in the last year of life. And so The options have significantly increased in terms of what we can do. And we've found tensions between what our responsibility is as a physician and what the patient would need and want. And that's really where this field of clinical ethics was born. It addresses concepts like confidentiality, decision-making, who makes decisions if the patient can't make decisions for themselves, truth-telling, like I mentioned, we all probably now agree that patients need to be told if they have cancer. And then you have this idea of surgical ethics. Surgical ethics is even newer as a field in terms of putting categories to the tensions that have existed for a long, long time. What makes surgical ethics unique, and I would say even further, spine surgical ethics unique is several things. So one, the relationships are quicker. It's not always a long-standing, ongoing, year upon year, conversation upon conversation relationship. So you have to build trust relatively quickly. And trust is really important when you're trying to balance that distinction between your own responsibility, your own decisions, and what a patient might need or want. The responsibility is different in surgery. So Peter Angelos, who is also a faculty mentor of mine from University of Chicago, talks about the difference between medical and clinical and surgical ethics. And one of the things that he talks about is this concept of responsibility. So if you're a medical doctor and something goes wrong, the patient has a bad outcome, people ask, what happened? What did the disease do to the patient? If something goes wrong in a surgical patient, they ask, what did you do, right? Then you're there. For us at Mass General, it's Thursday morning, but it's, it's an M&M conversation. It's what did you do that was wrong that led to this bad outcome or potentially contributed to it. And then there's this concept of the necessity of harm. So no matter what we do as surgeons, there's really not a way we can do it, no matter how minimally invasive we are, without doing some harm. We have to cut skin, we have to do something to a patient, drill bone, so that we can get to fixing their disease. And that's a little bit different than in administering medicines, et cetera. It's, there's a different line there. Then there's the anesthesia part. So the advent of general anesthesia, when we put a patient under anesthesia, they no longer have the ability to make decisions, nor do their surrogate decision makers, right? So oftentimes within the realm of what we're doing in a surgery, we are making on-the-fly decisions with the trust that we've established with our patients. We, of course, have some times where it's, this is too different from what we were intending, and we have to go talk to family or consider waking the patient up, but that is also something very much addressed in the field of surgical ethics. And then I think very pertinent to spine surgery is device innovations, conflict of interest, figuring out who, when, where gets devices, how they're implemented, how they're paid for, how they're maintained, et cetera. So that's the general overview of surgical ethics, why I think it's cool, why I think it's important. So this is a 4-box model from one of my mentors, Dr. Siegler, and it's something that I really love because I came into the field of surgical ethics just really interested in getting patients the thing that actually is good for them and getting the system and everything else out of the way. And I think that this model does a good job of that. Excuse me. So the first here in terms of clinical indications, these are the types of questions that we ask ourselves when we're trying to evaluate a ethical dilemma when it comes to clinical indications. Specifically, we separate things into principles. And so these are the principles of beneficence and non-maleficence. So beneficence, you want to do the right thing, do something good. Non-maleficence, do no harm, kind of like the very old school Hippocrates statements. And so, but here made practical in this model, which is what I like about it, are some of the things that we're actually asking. So what are the probabilities of success if we're doing a spinal fusion for back pain with minimal imaging changes? What are the probabilities of success, right? And so then how are we weighing what's beneficial and what's potentially harmful? What are the plans in the case of therapeutic failure? So taking care of a patient in surgery is more than just the operation. It's the perioperative period. It may be the next 5 years. It may be the next, 5 months, but figuring out what those plans are and does the patient know what's potentially going to happen if there is a failure of therapy. And then in the next box is this idea of respect for autonomy. And so this is the idea that capable patients can make decisions for themselves. And in order to do that, they need to be informed. And I'll talk more in our next case example about how that can be a challenge. And if the patient's incapacitated, someone else has to make the decision. And there are legal boundaries around who does that. And it's on us a lot of times to figure out who those folks are. I'll just put a quick plug in for making sure that your patients have healthcare proxies before going through a surgery, making sure you know who makes decisions for them and who they trust before they go to sleep. And then figuring out whether or not also folks have expressed prior preferences or advance directives. This third box is about quality of life. And so this again takes that principle of doing good, this beneficence principle, also non-maleficence and respect for autonomy, and kind of combines them into this more modern concept of quality of life. And I think that these are really key questions to think about. They actually can guide a lot of our decision-making in spine surgery. So what are the prospects with or without treatment for return to a normal life? Are there biases that might prejudice the provider's evaluation of the patient's quality of life? Meaning, are we saying, you know what, they're already housebound, what real difference could I actually make? Where the patient is telling you, it would mean everything to me if I could just walk from this room to this room, etc. And is the patient's present or future condition such that his or her continued life might be judged undesirable? Less so in our field are there plans for comfort and palliative care, but certainly in our spine oncology world, that's really important. And then this last piece is the principle of loyalty and fairness. Same idea, justice. You'll hear all these principles put together, but basically this idea that if within sort of the boundaries of our societal norms, something that a patient wants or needs, is it being justly distributed amongst the people that are potentials to receive that type of a treatment? Are there financial and economic factors that are playing a role in preventing patients from having that type of experience? Religious, cultural factors, disparities, that's where all of this kind of fits into those contextual features. Okay, so that was Ethics 101. Any questions about that?
Yes, I do have a question.
Great.
And like I said, Coy's going to come in and kind of, push me to the side. So I better get this question in. And I apologize in advance if you're going to cover it. Just tell me if you say it's going to be covered later. I think a lot of us will relate to this scenario, which again, if you're presenting it, just let me know, in which a patient and their family say, so Dr. Williamson, if this was your family member, what would you do? Right. And that is obviously a very common question. And it's funny, in my own, I've been in practice about 11 years. And in my own practice, I've changed a little bit. And in the beginning, I used to say, well, honestly, this is what I would do, right? I mean, this is what I would do if you were my family member, this and that. And then later on, I've learned that maybe that's not the best way to address that. Actually, I'm a firm believer that you should treat patients based on their wishes and their values, not yours, right? So I'm risk averse. If I saw an 85-year-old woman today and I don't know, maybe I don't want my grandma to have that kind of operation, but if this patient who's not my grandmother says, listen, I have pain, I have leg pain, I can't live like this, I'm willing to undergo the risks, I want the surgery. Well, hey, those are her wishes and her values. So how do you address that? How do you address that question? Dr. Williamson, what would you do if this was your family member? Do we have any ethical obligations to answer that in a certain way or not? That's my question. Thank you.
Yeah, that's a great question. And so I think, and there's a lot of good data to show that physicians, particularly surgeons, would not do the thing that we offer to our patients a lot of the time, actually. And we see it a lot in the neurotrauma world, where we're like, I would never have a craniotomy in this type of a scenario, but yet I would do it if my patient's family member said it was okay to do. And so the way at least I like to address that question is I like to sort of say, okay, the first thing I would ask my mom is, what does she want to be able to do, right? Like, what does she want to be able to do? What would a recovery look like for her? And I might even say, my mom's very clear that she does not want, like, my mom's one of those people that's like, please just let me die. And she's like got it written all over the place. And so I'll say stuff like that to people, like, honestly, my mom is really like, she would probably lean really far away from surgery because she's not a surgery person. And so, but however, I'm hearing from you that it's super important that you can walk in the mall with your, friends. And I think that, with the following risks, you could potentially do that. And so that's really where it comes into a personal question. And so I think I try to be really honest with, what I would do for my parents. I'm comfortable saying that, but I also totally agree that it has to be put back into this individualized context. And I will talk a little bit about individualized context around informed consent, because I think it's really important, because I think we've learned to just go like run through the list of things documented in our note, pop a smart phrase in, and but it's very individualized conversation. Thanks.
Great. Thank you for that.
All right, so with that, I'll jump into some cases. So the first one's about informed consent. And the concept here is respect for patient autonomy. So a consented patient has to have the proper information about surgery, and that can be different depending on who that patient is, what's important to them. But in order for them to make a treatment decision, they have to know what their options are, and they have to know the ups and downsides in general. I think everybody pretty much agrees on that. Okay, so here's the case. This is a 15-year-old male who presented status post an MVC to an outside hospital. This all happened very much remotely. Reportedly at the time had no sensory or motor function below C7. Here's the injury. Here's the surgery that was done. He had a decompression and fusion uncomplicated. However, after that did not regain any function, went to a rehab center. While he's at the rehab center, a new clinical trial becomes available through a collaboration in a different country. The procedure is not yet approved by the country's authorities. The patient will have to, by the home country, in this case, the US authorities, the patient would have to cover the cost of travel and extra medical bills incurred while abroad. Patient's mother is excited about this new procedure because she's been told that maybe he can regain a motor level or two or more, and potentially regain bowel bladder continence. The particular procedure that was potentially going to be put in place was using what we thought would be pluripotent stem cells from olfactory mucosa and injecting them into the spinal cord itself in order to hopefully regain spinal tissue or spinal cord tissue. And there was some data with a few patients in a study that they had improved motor levels and that they had improved bowel bladder continence. And so what do you tell the patient's mom? Start with that one.
Are you asking us? Are you asking the?
Yeah, I'm asking the group.
Right. Well, I'm gonna need some help here from our audience. So folks, as you know, you can always kind of chime in and engage with us in the chat box. I'm sure Dr. Williamson would love to see what a lot of other people think. But the question here, Theresa, is what would you tell the mom regarding whether you think this may work or not?
Yeah, like she's like, I'm getting ready. I'm going to remortgage my house. I'm going to fly to this other country because my kid is, is paralyzed and has no sensation below C7. And I've been told there's this option and, pretty much I'm going to take it. And so what do you want to say to her? What do you want to say to her son? Like he's 15. What's his role in this decision? What does she need to know? And then what is our role as a specialty in cases like this? Yeah. Or just any comments you want to make.
Sure.
Or no comments.
You started with a tough one, that's for sure.
I just went in hard, yeah, exactly. That's the whole idea of ethics.
Yeah, you jump in. I mean, these are obviously challenging because it's obviously you chose this case for a reason. I mean, you have a pediatric patient. You have a very anxious and worried mom, terrible diagnosis. And we, in our deepest of hearts, know that the potential for recovery is slim to none, regardless where they go and what type of what type of treatments they get. But at the same time, you don't want to kind of crush the dreams and the hopes of this poor mom and her son. And I think you're obligated to be truthful with them about what you know as a physician, as a neurosurgeon, what you know about spinal cord injury, but also perhaps get them the information about this new treatment from that group, from that country, and ultimately have them think about it and make up their mind. I think it's hard. You don't want to influence them one way or the other, but I think you have an obligation to tell them that, as far as we know, this is probably experimental and it's unlikely to change things. But I think you have to tell them that the chances are slim that this is going to all of a sudden make a big impact. I don't know. What's the right answer? You got to tell me.
There's no right answer here, I don't think. There is a right answer to the second question, the patient's 15, what's his role in this decision? So he does have to assent. Yeah, Desmond says not to give false hope, but not to take away hope. Yeah, there's this balance of hope versus truth telling that comes from clinical ethics that we're bringing over to surgical ethics. The patient's 15, so he does have to assent. Meaning that he has to be willing to participate. There are some cases, depending on the state, where a parent can actually have like sort of an adolescent teen and go ahead and say, no, they're going to get this treatment regardless, because technically they can't consent until they're 18. But most places recognize a need for a patient to assent so long as they're capable of doing so, which he was. What does she need to know? I think, Ali, I totally agree with everything that you said in terms of just really adequate information about what we know. And I think it's a balance to do that when you, in your heart, might be thinking like, oh gosh, please don't remortgage your house, right? Like, or, what is the worst that can happen? Or you're feeling guilty because you don't have anything else to offer. But really just a good, honest, objective assessment of what you know about that procedure or what you don't know about that procedure. And then I'll talk a little bit more about what our role is as a specialty in cases like this. I think the biggest thing probably that we're not good at is we have to keep track of them. So we have to keep track of how patients do so that we can give better information to the next patient. So the patient did go and undergo an olfactory mucosal cell implantation at the location of injury 4 years following the initial trauma. He had no improvement in his function. 12 years later, he declined and was no longer able to use his bicep, and then which he had some slight function in. And then imaging demonstrated an expansile mass extending from C3 to C7. This is actually when I met this patient with Dr. Friedman down at Duke. And so he had a large expansile lesion in the spinal cord itself. We did a resection of this mass and it turned out to be mucus predominantly. And so this patient had developed a mucus type of tumor that basically was expanding this whole area where it had been implanted and then further expanding the cord. So we resected basically as much mucus and kind of just evacuated as much mucus as possible until basically seeing changes in sensory and then stopping. And so I think that, in this particular case, one of the potential issues here is that this, since presenting and since publishing this case, I've gotten several different emails saying, hey, I also have a patient that this happened to, can you share what the outcome was? Can you share, whether or not surgery was helpful? And I think that just goes to show that in general, we don't have a great place to put this type of case. What happens to patients that go through a clinical trial and don't have a good outcome? What happens to patients that, potentially have a complication from a clinical trial or a complication from a new device, new innovation. And so thinking about ways as a specialty that we can keep track of ourselves and make sure that we have good understanding of these types of outcomes potentially may have changed the patient's mom's mind at this particular juncture when she was making a pretty vulnerable decision. And so just sort of summarizing what I think some of the ethical issues are for this case, given the possible long-term consequences, and questionable neurologic benefit, it's crucial to better study this procedure prior to implementation. And then the population seeking treatment is exceedingly vulnerable in their hope for a cure. And I think that's what Desmond's getting at. So making sure to be contextually appropriate to that vulnerability, because we have lots of data that shows if you're vulnerable, when we think of spine patients, particularly patients that are in a ton of pain, pain begets vulnerability, right? We've all seen it. Do whatever for me because my back hurts so bad, my leg hurts so bad. And being able to shift the context of your conversation around consent is really important to be able to address that vulnerability without necessarily just shifting it towards a procedure, because that often feels like the only mechanism of hope for patients. And so this is some ideas about how to do that in informed consent. So this is a trial that came out in 2020, done by Gretchen Swarzy at the University of Wisconsin. And so this is a study about effectiveness of a question prompt list for basically getting informed consent in vulnerable patients. In this case, it was for older patients, I believe also with poor medical literacy. And what they found is that the surgeons actually really loved this question prompt list that they would send to patients beforehand to consider. And so it actually, Peter Angelos wrote this kind of cheeky review on it saying, interventions to improve informed consent, perhaps surgeons should speak less and listen more. And so sort of figuring out where this vulnerability is coming from, what they want, what other options they feel, what doors they felt like may have been closed for them, can really help to understand what the limitations are and where potentially this lack of hope is coming from, or this unrealistic expectation. And so that can be a really helpful process. This is in JAMA Surgery if anyone wants to check it out. And to answer the question, Matthew, about informed consent, or sorry, bioethics consults, yes, we can get a bioethics consult through the MGB system. And then some other thoughts about informed consent. I mentioned the special type of informed consent called assent, which is the reason why I chose this 15-year-old patient. And then this definition of vulnerability, which is an inability for self-protection, is the definition that I like because it's broad. There's a really good study or paper about informed consent vulnerability and the risks of that in nursing ethics. And I would suggest looking at this article if you're interested in the topic, because it broadens the definition of vulnerability beyond just the social scope where we sort of think about it with socio-demographically vulnerable populations to a contextual, individualized vulnerability, meaning I'm in a lot of pain, I just lost my job, all the things that come in context. And I think if we put the two together and think about how we can sort of prompt patients to ask more questions and to tell us more about where they're coming from, we can potentially get a better individualized informed consent and be less subject to the risks of vulnerability. And so they talk about some ways to mitigate vulnerability induced, I'll say, over or underutilization of proceduralization. And so they talk about this concept of relational ethics and some ways to improve it being mutual respect, engagement, embodiment, and environment. So being sort of aware of all of those things. That's the first case. Any other comments about that one before we go on?
No, I think. No, thanks, Theresa. I think we can go on.
Cool. So this is the second one. So this patient, I'll talk about sort of the principle of justice and fairness with this case. And so this is an 80-year-old woman, African-American, who has a history of severe lumbar spinal stenosis. She comes in with severe neurogenic claudication and is basically unable to walk outside of her house. One of the biggest things was that she couldn't get to church, couldn't get to the grocery store because she just really couldn't take too many steps. She had tried sort of pain management, physical therapy, injections, and was offered a laminectomy. However, when she was offered that, sort of immediately said, no, I don't want surgery. And then when prompted to sort of ask a little bit more about why, it was because she didn't want to stay in the hospital. And so when she was told that she could do a same-day discharge, she actually ended up having surgery, did really, really well, and then didn't even come to post-operative follow-ups because she was so happy with her outcome. So I think the big question here is, why doesn't this patient want surgery? And so I'll take any comments in the chat, but then also just sort of give some of my own ideas. So there are patient factors. In this particular patient, it could be that she had a, experience of herself or her family member in a hospital that left a bad impression. It could be that she just has been watching the news and seeing all of the issues with health disparity. It could be that her family or herself lived experiences of health disparity or racism in healthcare. It could be that she has a lot of responsibilities at home and isn't able to make the time for a surgery. It could be the provider. She doesn't trust the provider. She doesn't trust the provider's institution. There's a whole host of factors. There's the environmental factors. Maybe she lives too far from the hospital, can't get there. There's all kinds of different reasons why someone might not access a resource that it could be consistent with their goals. And so I'll just talk about a study that we did briefly, where we looked at patients here in the Mass General Brigham system between 2015 and 2022, who had routinely completed PROMIS patient-reported outcome measures, particularly in physical function and pain interference. And so where we looked at, patient symptoms and then the ultimate treatment assignment. So did they get conservative management? Did they get physical therapy, injections, or surgery? And so what we found out of these 22,000 plus patients that completed a PROMS was that the predominance were covered, the predominance of Black and Indigenous patients of color were covered by Medicaid versus white patients. That our Black and Indigenous patients of color reported more pain and less physical function activity on their PROMIS baselines, but however, were less likely to receive an interventional treatment. And so I think this data speaks a lot to justice and allocation of a resource that could be helpful, particularly for the patient like the one that I brought up. So I think the take home from here is that there's patient-reported outcome data showing that patients of color have high burdens in terms of disease, high pain interference, low physical function, however, are still less likely to receive an interventional treatment. And we don't know whether that's on the patient side, provider side, environment side, but it's a really important issue to potentially address if we do, which I know we do, believe that spine surgery in the right cases can be a meaningful quality of life change. And there's obviously lots of data to support that idea. So in the ideal decision-making realm, you'd have a patient with their symptoms, you'd have a patient with their goals. In this case, I, have severe neurogenic claudication. My goal is to get to church and to be able to get to the grocery store. I've sort of exhausted a lot of my other options for treatment. I am going to have a laminectomy because that's my most goal concordant sort of pathway. But sometimes we get lost in that pathway and we don't really understand where we got lost, why that patient didn't make it through that process. But I think it is on us as a specialty to sort of understand and try to figure out ways to equal the playing field when it comes to patients, not just patients of color, patients of different socio-demographic backgrounds for whatever reason, just that same idea of that vulnerability context that aren't getting access to the same resources. And so I think that this really brings in this fourth box of contextual features when it comes to the principles of loyalty and fairness and how we go about distributing resources, particularly when we live in a really high resourced environment in general in spine surgery, depending on where we are. So I think the big picture questions of this, working on a neurotech justice grant right now through the Dana Center. And one of the big questions we're talking about is justice achievable and who decides what justice looks like. And so I think when we think about this from a spine surgery standpoint, it's really important to have the voices of our communities and our patients to figure out what their needs are and what their barriers are so that we can do a better job improving access to care.
Hey, Teresa, I have a question for you. Sort of bigger picture, so I think not only in neurosurgery, but I assume across all disciplines, there's, at least some evidence to suggest that major disparities do exist based on insurance status and ability to pay and stuff like that. So what type of system gets rid of all that?
I'm glad I'm not running for office. This is why I do ethics, so I don't have to actually answer any of these questions. I can just give hypotheticals. No, I'm just kidding. I think that I think that a system in which a surgeon or surgeons is adequately trained to communicate with patients and to assess sort of disease burden and choose a procedure, that I think that would be one, and then that patient can get that procedure, right? Like, and we get rid of the bad actors instead of having prior auth, in my mind. And so I think that's one big thing, right? Because if you take prior auth in general, you're already creating a scenario where certain patients have to be advocated for. So a lot of work has to go into advocating for those patients. And if you do that, then you've maybe created a scenario where certain people are not going to have access to it. And it's hard because I think payers don't believe in spine surgery a lot for good reason, because we do a lot of spine surgery on people that we probably shouldn't. And so I think we've lost trust in some ways in that regard. There are some programs like Blue Cross Blue Shield. I think of Michigan has a gold card program where providers for them that, sort of choose the appropriate surgeries and have consistently shown to do so, actually don't have to go through that process anymore. In Massachusetts, they're moving towards shared decision-making. And so with shared decision-making, and I'll show a little bit about that, if you are documenting that you're doing shared decision-making, it's actually going to sort of take away some of those payment barriers, which is really interesting. They're actually planning, I think, starting soon in ortho, where they're going to send a patient a letter and say, did your doctor adequately explain the surgery, the risk, and the alternatives? And if the patient says no, that's it, no surgery. Which you can imagine how that could potentially become an issue. I was like, oh my goodness, first of all, good luck trying to reach everyone by mail. And then I think the important thing, so that's assuming that our patients get to a surgeon. And so the other systems issue is the access issue. And so I think in that issue, I would like to see a system where there were more sort of spine centers of excellence that had equitable access. We're working at MGB on a United Against Racism project to try to improve access to MGB, and then also once people get here to improve the experience. And so we're surveying patients, figuring out why they couldn't get here. We're going and doing education with PCPs in the communities that we don't commonly see in our hospital, and trying to figure out, because there's a lot of myth about spine surgery, right? That people don't come. And then probably you have to get people health insurance, which I've been avoiding saying that I like universal health care because I'm not sure about that.
Thank you.
So here's some examples of that shared decision-making work that probably will go into payment decisions in the future. So this is a project that we're currently working on. It's a decision aid through HealthWise that does lumbar spinal stenosis. And so basically it talks about which treatment is right for you. And it has lots of these little figures that say these are the non-surgical treatments. They have fewer risks, but they may not work as well to relieve your pain. And it goes through all of these things. It's supposed to be written at a 7th grade level. We've been doing this as distributing these aids as a collaboration between ortho and neurospine as part of a feasibility study to try to better understand if this would help with any type of lack of access to surgery that comes from some of those patient factors related to understanding what's actually potentially going to happen and what the peri-op course would look like. So we've distributed now close to 200 of these and gotten a follow-up response rate in terms of surveys to see what patients think of this type of a decision aid, and so far have about a 48% response rate. We're hearing from most patients that they think the decision aid is really important and really helpful. And then these are the types of comments we're getting back from patients. So some of my favorite from the very important, never had a doctor discuss reasons not to have surgery. And it's nice to know all the options before deciding to do surgery. And then patients don't always want to make a decision right then and there. So it's helpful to be able to take some materials from the visit to help with decision making. Patients get a lot of information thrown at them, and it's helpful to have it all in one place. The decision aid allows patients to take the information from this visit home with them, and it's important because it helps remind the patient in case they forgot what was said in a consult, which is really key. This is the best thing I've ever received because I knew nothing about my condition or treatment options. And so I think some of these things are potentially really important. The work's still out there to see whether or not it improves equity. That's sort of the next phase of our trial. Okay, so with that, I'll go on to another case. I sort of put the more warm-up cases in the beginning, and I think this one's maybe a little bit harder. So you receive a transfer center call from a provider stating they've done all they can do for a patient with osteomyelitis discitis. They, in their op note, say they've taken down the pedicle for a transpedicular ventral decompression. The patient is worsening for several days. You accept the patient in transfer. On MRI, there's severe ventral disease and continued compression. At surgery, there's a laminectomy only and no facetectomy and no transpedicular work. What do you do? Other than obviously do the transpedicular decompression, that part, we're going to say that part's going to get done.
Ooh, this is a good one. We encourage people to chime in the chat box, or one of the other hosts to chime in as well. But that is so many implications here, right? Because I'm sure everyone's seen patients where, the surgery that they've been billed to have, you can tell pretty clearly on imaging that they haven't really had done. And so, what's the professional and, moral way to escalate that? I'm excited to see what you have to say.
I'll give folks a minute if anyone wants to put anything in the chat. I think some of the really critical questions to consider here are what, if anything, do you tell the patient about their prior surgery, which I think can be a real challenge. What do you say to the transferring surgeon, if anything? So are you required to give that feedback, presuming that surgeon wants to get better, like we all do? And we all, make mistakes or, do surgeries that we don't think are perfect. And so do you have that conversation at all? And what happens if that surgeon calls you the next week and it's the same thing, or it's a slight variation on that case and it just keeps being a repeat issue?
So I would say that, if I can just go ahead and chime in,
yeah.
I think you tell the patient that, what they were told or what you were told that they had done doesn't appear to have been, completely done, if you will. But in no way do you sort of, place blame or distrust on the, the original surgeon. But I do think it's appropriate to, call that other surgeon and ask sort of, their thought process. And, to your point, everyone makes mistakes, or, different people have different definitions of X, Y, and Z. But then I think if it becomes a habit and patients are harmed because of it, I think that's a reasonable point to kind of escalate things to, state and, subspecialty boards. Maybe not after like one offense, but if it's like a repeated offense, I think that's probably reasonable. Someone just chimed in. Okay, so Dr. Burchuk says, take care of the patient, everything else is secondary. Dr. Terry, our friend, says, this is a tough one. I usually say I wasn't there at the original surgery, so my understanding is necessarily limited. That being said, this is what I found, and this is what I did to address the problem. I think those are great. I think both are great answers.
Yeah, I think both are great answers and variations on the same theme of that sort of like taking care of the patient in front of you, and then making sure that as you address it, this is what I found, and just giving your honest assessment. I know we get asked a lot. I think spine surgery, it's pretty common, right? Because there's so many revisions for people to say like, but my first surgeon really botched this, right? Or my first surgeon really didn't do a good job. And it's, I think, really key to take care of that patient. And I agree with Dr. Terry of, I wasn't there. I'm not sure, but this is my thoughts about what's happening right now. So I think the principles that this brings up, so one is respect for autonomy. And so I think what Dr. Terry said is really important, because that gets to this respect for autonomy. So saying nothing probably doesn't respect that patient's right to be informed, but saying this is what I found that, the facet was still in place. I found that, the joint was still there. I took down the pedicle. I did the ventral decompression. This is what it looked like at the end. I personally think is sufficient in that regard. I think probably saying nothing about what you found and would potentially not be honest enough to the patient, particularly a patient that's been weak for several days and may not recover because of the type of compression that's sort of been there and been sustained. And then there's this idea of sort of beneficence balancing with non-maleficence. And so the idea that we as a specialty, or we ourselves, do need to sort of ensure the appropriateness of our skills, of our knowledge, and our ability to do what's right for patients through this principle of beneficence. And then this idea of non-maleficence or avoiding harm. This comes from a paper talking about complications, which I'd be happy to share. This is that idea that, we need to sort of consistently exercise good judgment. Doesn't mean that we're not going to make mistakes or have complications. I think probably no one on this call is in that category. But recognizing limits of one's competence, recognizing infection control measures and quality improvement programs can all be derived from the principle of non-maleficence. And so this is that idea of learning from a complication. I agree that I probably would not reach out to that surgeon after, a one-time thing. I think it would be a very difficult conversation to have and not sound like you were sort of shooting from your high horse. But I do think if there's sort of this principle that is consistently violated, it is important for us as surgeons to, at the very least, consider a conversation exploratory to try to figure out what's going on, or like Dr. Than mentioned, a discussion with medical board or report from that standpoint. And I think the reason why this is important, so this just came up, and a few of us that do surgical ethics were asked to sort of comment and discuss it. This New Hampshire surgeon who had the worst record for malpractice death settlements in the nation, and was a really high earning cardiac surgeon at a hospital. Well, I guess you can see it was Catholic Medical Center, I believe, because it's now all published everywhere, so there's no privacy issues here. But basically had been sued, on a countless numbers of times, had a close relationship with the hospital CEO and was sort of like continuously kept at that hospital, ultimately really leading to numerous bad outcomes for a patient. Our specialty is no stranger to this type of concept of propagating someone who's not doing the right thing. And then on top of that, a real loss of trust for patients. I think right now, this is a really interesting article in Proto Magazine at Mass General Hospital, where they talk about the trust crisis that sort of arose during the pandemic, that our patients just don't trust us as much as they used to, right? Like public health, medicine, for regardless of your politics, has sort of been undermined in a big way in the past couple of years. And so the worst thing we can do in some ways is allow for things like this to happen as a specialty. Valerie Koch, who's a lawyer at University of Chicago and part of the clinical ethics program there, talks a lot about, she's a lawyer who really doesn't want lawyers involved in medicine. And she talks a lot about how the responsibility at some point is going to come to either subspecialty boards, subspecialty organizations, or individual surgeons to sort of develop and maintain an ethical code in our own field. And I know our field obviously has a code of ethics. We have ethics committees in our big national organizations. But it's important to remember that we are maintaining sort of a public trust that our patients rely on to trust us for their care. Right. We've got a couple minutes, so I'll just run through the last one and then answer any questions. Okay, so this is an example I gave in the surgical ethics conference in June at the Harvard Center for Bioethics about my email inbox when I started as a new surgeon. And maybe some of your email inboxes look similar, but your business is extremely important to me. I want to build a relationship where you can trust us of all your needs from an instrumentation standpoint and technology. Not sure if you were able to watch the webinar on the new technology that he gave yesterday, so I thought I'd share the link in case you're interested in checking it out. I'm curious if you had a chance to give our MIS screw system a try. Is there anything particular holding you back from giving it a try? Here's the quote, new technology surgeon training exam, start the quiz later to say sort of like, I'll help you get through it so that you make sure you can pass and use this new technology. So there's sort of no getting away from how much industry plays a role in our field. If you ask ethicists, just sort of general ethicists or clinical ethicists, they're very dogmatic about, often very dogmatic about the involvement of industry. I don't tend to stand in that place because I think our relationships with industry are integral to everything that we do. But it's something also to be considered and to acknowledge as we sort of try to drive the field forward. So some of the big questions that I think come from this type of a case are, should there be a relationship with industry? Which devices should you try? Like which emails are okay to answer and which ones aren't? How much training is a surgeon obligated to pursue to do a procedure? So is, doing that online quiz that they sit next to you and help you kind of get through the answers enough to say that you can do something? How different does it have to actually be from what you already know how to do for you to really even have to go do a new training, right? If it's just new MIS screws and you've put in, thousands of MIS screws, what's the difference? And then how do we monitor new device safety in our field? And so some ideas there in terms of commercial relationships. So not bad to have commercial relationships. Patient care just must not be affected by economic interest, commitment to, or benefit from professionally related commercial enterprises. And then conflict of interest, sort of professional judgment should not be influenced by other interests of the provider. And I should say that conflict of interest always gets a bad rap in terms of industry. But a lot of the research now that's coming out is in academia about conflict of interest related to research, promotion, the desire to put out positive results, et cetera. So how do we manage our relationships with industry? I think being forthcoming is really important. I put this picture up of sort of one of our ORs at MGH that, there is an awful lot of technology at play and we need other people to help us. Like we cannot manage everything that's happening in the OR at every time. So we can't really rush to separate industry from medicine, but we do need to discuss the benefits. And I've actually gotten into the habit now of letting my patients know who and why is going to be in the room for in terms of industry representatives. I think it's important. They're going to go to sleep. There's someone else in there. I think they should know. And most patients are like kind of curious about it. They think it's interesting. Very few, have any objection, obviously, to industry being in there. But I do think it's a nice and important disclosure to let patients know. They have shown in terms of data that if you disclose to patients like, I consult for this company, et cetera, that really doesn't help or inform their decision making too much. So I tend not to disclose that type of information. And so, in terms of managing those relationships, don't rush to replace clinical judgment either. So this is a really interesting ethical article in the Hastings Center. industry technicians embedded in clinical teams. And this talks about the fact that, industry representatives, although we hope and believe that they are most interested in the patient's well-being, they also have a huge, they have a responsibility to their stakeholders, to stock share owners. They have a responsibility to people all over the map. And so really trying to think through who are these people in the room, and not depending on them for any type of real clinical decision. Obviously, at our hospital, we definitely rely on them to help us load instruments, do things with nurses that are spread thin and don't always have every different type of expertise. But I think that's something important to consider as well. Organizational ethics, should the device even be there, and who should be at the table? In my opinion, people should pretty much recuse themselves from decisions if they have a sort of large financial incentive related to that type of a decision, and let the technology speak for itself. It's, again, a big trust and PR issue, but then also can potentially limit technology in a single direction if we're not sort of evaluating the field on a whole. And it's not to say that leaders can't be involved with companies. It's more just in those sort of very specific decisions. So in summary, I think new technology should have a benefit. You should be competent, and that's sort of some commitment to formal study, figuring out what you're going to do if you get a complication. It's not the same as a certification or an online quiz. If it's research, it's research. So not trying to sort of peg that into a clinical loophole. And then making sure, as we're talking to patients, that we're informing them adequately about new devices and we're avoiding that vulnerability phenomenon again. There's some really good application statements for surgical innovations and position statements. Ideal framework is a really helpful one. And then I think probably the most important thing is that we monitor this and create places where we can provide negative data about industry sponsored studies or industry related studies, just so we can get the best clinical outcomes for our patients. So before I end, I'll just thank everyone at MGH and the spine team. Dr. Shin, Dr. Masad, and Taylor Mitchell did a lot of this work. The MGH Health Decision Science Center, all the folks at Duke that helped, and then Dr. Than and the team at Virtual Spine, Dr. Baj, for inviting me. And then support from MGH Intramural Award and the Dana Center for Neurotech. Thanks.
Theresa, that was just fantastic, and really appreciate your time this evening. This will be uploaded to YouTube, and certainly we'll get hundreds of views. One question, before we leave, certainly when I was a idealistic med student, maybe young resident, I always thought that no way would industry influence like my decisions, right? And I think it really totally doesn't. But all other things being equal, let's say let's just, for the sake of argument, say all screws are screws, and let's just say at Duke that they all cost the same. I'm probably gonna use the screw with the company that I have a relationship with, right?
That's
so
right.
Is that wrong, or should I be thinking about it in a different way, or?
I think it's not wrong. I think it's not wrong in the sense that, we do develop relationships with people that we trust on our teams, and that's part of it. We depend on folks, in the OR. I think probably what could lead to something wrong is when you use it and it's not all the same and it doesn't all cost the same, and I'm bringing this in because I have this like pretty clear vested interest, or even worse, you're still using it despite sort of some poor outcomes just because of that personal relationship. But it's something we're actually looking for and doing in the research is managing this transition between training and young faculty, which I obviously just did. And it's very tricky because when you're a resident, like everybody's so nice to you and you're like, great, everyone's so nice to you. And then when you're an attending, everyone is like, okay, like now you need to actually use my stuff. And managing those pressures, I think if you are truly clear that you're doing the right thing for the patient, you're totally comfortable. But if you're like, oh, I got to try this thing because so-and-so keeps emailing me, I think that's probably problematic.
Great. Well, thanks for making me feel better about myself.
Yes, absolutely. Anytime.
All right. Well, thanks again. Thanks for everyone who joined. Yeah, you got a shout out even from Libya. So that's really
awesome.
Cool.
Thank you.
And like I said, we really enjoyed having you, and we look forward to the next
Thanks,
time.
everyone.
So thanks again, and we'll see you all next week.